Good morning, everyone. So I'll be presenting this case. Who's a 36-year-old gentleman hailing from Nalasopara, works in a furniture company. He had no previous comorbidities. His reported ECOG performance status is suggestive of ECOG performance status of 2, who presented with chief complaints of right-sided testicular swelling since 6 months and low backache since 1.5 months. History of presenting illness. So he presented with his complaints were for painless right-sided testicular swelling since 6 months. It was gradual in onset and gradually increasing in size. He consulted a clinician initially for this after 1 month of the onset of complaints, and he was told to have some fluid in the testes, and it was suggested surgery, which he did not undergo. He did not undergo any evaluation at this point of time in the form of scans. Since the last 1.5 months, he also has complaints of low backache, which is lower back but ill localized. It is gradual in onset and gradually increasing over the 1.5 months. It's more with activity and less with rest, but present at rest also. It is more at night, and he has only some relief with analgesics that was prescribed to him. He has history of cough with hemoptysis since the last 15 days, which is scanty sputum with the blood tinge. He does not have any history of exertional dyspnea or chest pain. He has history of weight loss of around 5 to 6 kg in the last 2 weeks. History of decreased appetite in the last 2 weeks. He has not noticed any swellings elsewhere, specifically no neck swellings. He has no history of headache, vomiting, or any history such as of seizures. No history of pain abdomen or abdominal distension. No history of jaundice. With respect to past and personal histories, no previous comorbidities, no history of tuberculosis in the past, and no prior medical or surgical admissions. Personal history, significantly the sleep is disturbed because of the pain. His appetite is decreased, weight loss is present as mentioned previously, and bowel and bladder habits are regular. He's married with 2 children, 7 and 9 years of age, and he has no addictions. There's no family history of malignancy. Treatment and allergy history. He was initially evaluated, other than the initial, he had initial evaluation for backache and was told to have spine problems and was given analgesics, but there was no relief. And when he started having complaints of loss of appetite and loss of weight, he underwent evaluation and he was told to have a tumor in his abdomen. At presentation, the medications he was on analgesics for backache, which is tramadol and aceclofenac. He has not undergone any intervention for the testicular mass, and he has no history of any drug allergies. So summarizing, I have a young male with no previous comorbidities, with history of long-standing painless testicular swelling and subacute, probably referred back pain and significant weight loss and recent onset hemoptysis. So I would consider a diagnosis of testicular germ cell tumor with possible retroperitoneal, likely lymph nodal metastasis and pulmonary metastasis.
So if you have to choose in the histopathology of a germ cell tumor, which one you will prefer?
Considering 6-month history, I'd go for seminomas.
But other factors?
Other factors are featuring more of a non-seminomatous.
Yes, mostly the involvement. Basically, in our setup, usually the patient present very late. So even a non-seminomatous germ cell tumor, they do not. So the presence of a bulky retroperitoneal lymphadenopathy and a hemoptysis usually suggests because in seminoma usually it follows more indolent course than this. Within 6, it takes around sometime the 1.5 year to 2 year. They usually grow locally, and then the only very rarely they present with a hemoptysis, mostly with a very large heterogeneous bulky abdominal lymph node can be there, but hemoptysis, I don't remember that any patient of a seminoma presents with the hemoptysis. Akhil, do you want to add anything into this section? And Nandini?
Yes, sir. I would just like to ask if there is any other differential diagnosis in your mind.
Akhil, can you come a little closer to that? Your voice is not very clear.
Yeah, Alok, any other differential diagnosis in your mind?
No, sir. I couldn't think of anything else.
Okay. If it had been not so young male, middle-aged or 50 to 60 years, then you would have kept any other differential?
Yes, elderly with testicular swelling, lymphoma needs to be considered.
Okay. And apart from these history, have you asked about history related to fertility?
He's married. Oh, specifically, no. Okay.
Okay.
He's married with 2 children. Sexual history.
Married with 2 children, that clears most of the doubts actually. So he's fertile. Okay. Sir, this was from my side.
Nandini, do you want to ask any question in this section?
No, sir.
So I think one question which you could have asked is from the most important. What is the most important one history in which patient we should have asked in the testicular cancer, which has a clear-cut impact in the. So definitely you should have asked about the whether the testis. Sometimes the patient might not be aware, but sometimes they may be aware that the testis was initially one scrotal sac was empty and there was some surgery done, and then the testis was brought down. Because among the risk factor or among the etiological factor, I think the most important is the cryptorchidism. So that history you have to rule out, because sometimes the patient in the childhood they might have gone this surgery and they may remember. What is the importance of this cryptorchidism in testicular cancer?
This cryptorchidism, there's increased test of testicular tumor more if it is unoperated, and even if they've undergone orchiopexy, they have a risk of still have a risk of testicular tumor.
So in case of undescended testis in the intra-abdominal versus the testis which has brought down, what is the probable incidence or roughly any idea?
10%. And
so read little bit about this, because sometimes some examiner they want to hear these percentage or the number. So the undescended, if it is intra-abdominal, I think the risk increases by 10 to 20 or 30 fold. But if it is brought down, so what is the optimum age when it should be ideally brought down?
Less than 1 year.
So it varies in the different literature, but definitely some say that 18 months, but definitely it should be below 2 year. So even if the testes have been brought down to the scrotum below 2 year, even they are around I think 5 to 10% risk. That number you have to check, but definitely it's in the 1 digit. So around 5 to 10% risk of developing testicular cancer in a crypt of testis which have been brought down at that age. So why what is the theoretical reason for a crypt orchid testis to have an increased incidence of testicular cancer?
Not sure.
I think so. The probable there are two hypotheses, but most it is said that the intra-abdominal estrogen exposure to the developing kidney, this testis may be one of the risk factor. And secondly, if the testis is brought down to the inguinal versus abdominal, where the risk is high. Inguinal, so the undescended testis can be in abdomen, can be in inguinal canal also. So where is the risk high?
It's abdominal.
It's abdominal.
Yes.
So even if suppose the 7-year kid has come to your opinion where the testis is undescended, do you still advise for the testis or the putting into the scrotum or not? 7 or 8-year kid, family coming and doctor has told that the orchiopexy is required. So if yes, why? If no, then why?
I am not sure.
Any other third year can, if you have any. So why we need to do the orchiopexy in a undescended testis irrespective of the, what is the benefit?
Alok, think based on the location, what will be the advantage in follow-up?
I mean, monitoring,
Yes, yes. So that is the answer. Even
Yeah.
so, that is the answer in that. So even if the orchopexy will not reduce the incidence of a chance of developing a testicular cancer, the monitoring of a descended testis will be easy compared to the intra-abdominal. So a USG testis is easily can be done in a testis in a scrotum rather than in an abdominal. So from that point of view, even if it is undescended testis, find at any age, we advise to go for a orchopexy so that the monitoring, so in subsequent monitoring will be easy compared to that. But if you want to reduce the incidence of a testicular cancer, then preferably it should be done. Some says 18 months, some says two years. So preferably it should be done before 2 years if you want to decrease the incidence.
Yes.
Nandini, anything you have to ask in the initial?
No, so I agree with you, and this is one of the most common questions they ask in the exam. So the incidences and the thing better to read and find the exact values, because it is always asked in all cases
So
testicular.
other Alok, what are the other risk factors for a testicular theoretical? Because the treatment part you all will know. So therefore, I'm just concentrating on the initial part. So what is the other risk factor for testicular cancer? So the term which is being used is that Nandini, or you can correct me. I think testicular dysgenesis syndrome is the word which is being used. So the data for those couple who have some sort of sperm abnormality, agiospermia or oligospermia, theoretically they are at increased risk of developing testicular cancer. Similarly, the Klinefelter and all that, where the testicular dysgenesis is, they are prone to develop the testicular cancer compared to the normal. So I think testicular dysgenesis is one of the predisposing factor which puts the person at risk of developing testicular. So cryptorchidism and the testicular dysgenesis is one of the. Is there any theoretical family history? I think this question was yesterday asked in our meeting. So if the patient having a history of testicular cancer in father, is there any increased incidence of a testicular cancer in son or patient's brother? Although we don't know the exact reason for that, but whatever the data we have, it's around, I think, five-fold increased risk of developing a testicular cancer in a son. Or you can check the number, but what I remember, I think it's around five-fold increased risk in son and brother. Why it is there is just no specific foci which is or the locus which has been identified for this, but whatever the data says, around five-fold increase risk for a family member of the.
Yes.
So other thing is that you should, as you said, there is no other differential diagnosis, but sometimes the examiner will ask the, suppose in this patient the things are easy because you have a retroperitoneal lymphadenopathy, you have a hemoptysis. So suppose that if the mass would have been located in the scrotum only, then what would it, the question which was asked you earlier, suppose you leave out the abdominal component and the lung component, which is confined only to the testis, then what are your differential diagnosis?
Like of a solitary testicular swelling, sir? Like,
Yes.
okay. So, solitary swelling over progressing over 6 months could be hydrocele, epididymal cyst.
But I will suggest that in examination, when you have to ask, I think go by the non-oncological and then probably oncological. So it may not be always oncological. So non-oncological, these are, so if you say like this, 1, 2, 3 non-oncological differential diagnosis, and these are the oncology. So the examiner is clear is in mind that the student knows about both aspects. I think Dr. Kumar is also joined. I think Dr. Kumar, you can also ask if, anything which is relevant to the this thing. I think is so. So tell me the differential diagnosis of this oncological and non-oncological of testicular swelling in a young male.
Non-oncological hydrocele, epididymal cyst. And
Other more common than that? testicular torsion, epididyma.
Orchitis.
Yes, so these are the oncological.
I'm not sure. Lymphoma, if it was an elderly male, for
But still you can say that those doesn't fit into the
birth.
or other apart from testicular germ cell tumor. What are the other differential in this?
Lymphoma, leukemias can present with the testicular swelling.
And rarely, sometimes the age is slightly on the higher side, but RMS, sometimes the non-just germ cell tumor like the Sertoli cell, Leydig cell, they can present in this age. So definitely the lymph is not a common, and this leukemia, deposit of leukemic deposits in the testicular cancer is the day. In elderly patient, what will be the oncological differential diagnosis? Most common in a patient more than 50 or 60 year?
Lymphoma, usually DLBC.
No. I think secondary involvement of a testicular cancer will be more common. So what are the cancer which can go to the testis theoretically?
I'm not sure.
Prostate cancer, lung cancer, melanoma. I think these are the probable cancer which can have. So you should know about the differential. But Akhil was saying that you should have 3 or 4 non-oncological and 3 or 4 oncological differential diagnosis in your mind. Whenever examiner asks, you should be ready to, though it is, you can say that it's unlikely because, but these are the probable which I can think in my mind. So you should be ready to pick 2 or 3 differential diagnosis.
Yes.
Okay, go ahead.
Also, moving ahead with the examination. So the young gentleman, conscious and cooperative, well-oriented to time, place, and person, with a BMI of 21.9. His vitals, temperature is 98.6, pulse was 80 per minute regular, BP was 110/70, and his respiratory rate was 20. He had mild bilateral pitting pedal edema. He had no palpable significant lymphadenopathy. He had no pallor or icterus. Skin and oral cavity was normal. This is on general examination. On systemic examination, positive findings is on per abdomen examination was soft. He had non-tender. There was non-tender hepatomegaly around 4 centimeter palpable below the right costal margin with a liver span of around 18 centimeter. There was a right testicular swelling, which was 6 by 6 centimeter and hard in consistency with no evidence surrounding fluid. On respiratory system examination, trachea was central. He had decreased breath sounds in the right infrascapular area and a dull note on percussion and in the same area, and vesicular breath sounds in all other areas. Neurological examination, higher mental functions were intact. Cranial was normal. Motor and sensory examination was normal. There was no vertebral tenderness, especially in the lower spine. Serious S1, S2 appeared to be normal. So at the end of the examination, the positive findings were that of mild bilateral pitting pedal edema, mild hepatomegaly, a testicular swelling, and some decreased breath sounds in the right infrascapular area. Could be an effusion, could be a mass, and yeah. So no additional, I think I could add in the clinical findings.
Anything specific in the general examination which you should have also noted? So I think 2 things generally the examiner wants to know about the in a patient with a high beta SAG, sometimes there might be a gynecomastia. So that is one thing, and the features for Klinefelter, some examiner wants to see. So I think you have to read about. I think one is the this what we call it as a span, the arm and something span that. So the Klinefelter features should be come into the examination, and that one thing which I think you could have added into the general examination. Anything? I think Dr. Kumar is also there. I will request him to ask any relevant, because if he can ask some further questions, it would be useful to the students.
No, thank you, Amit. It's going good. Continue.
Akhil and Nandini, you want to ask anything for in the general examination? Anything which you want to add?
And definitely, sir, features of gynecomastia should be mentioned in the examination as highlighted. And also, Alok, can you enumerate some points which should be noted in testicular dysgenesis syndrome or Klinefelter syndrome, which can be noted on examination?
I think tall stature, gynecomastia, features of like if there's no palpable testis or a small testis.
Yes. I think that is another thing which could have both the other testis.
The testis.
Yeah. Okay.
So they ask the arm span to the height ratio. So if somebody has a tall stature and looks like maybe one of the dysgenesis, maybe it might be good to measure the arm span also.
Okay.
And indirectly the secondary sexual character also, if there is any very relevant which is apparent on the examination, that may help. I think these are the things which could help. But I think sometimes some examiner, I'm not sure who is going to be the examiner this side. Sometimes some examiner are very, so I think last year when I was the examiner, whenever any student no icterus, no pallor, I think they just get why, how commonly have you seen a testicular cancer presenting with the icterus? So sometimes you have to be little bit, they want, because even in early stage breast cancer, you're not presenting a case. Some don't want to see, because then the viva will go in a different way. What is the amount of the liver parenchyma to be involved at representing? So how commonly you see a patient without a lymphadenopathy? How common is the liver involvement? What is the, so sometimes they don't want to, at least if they want any other, then you can ask. So I'm not sure how to, because some examiner doesn't want to. So if you have mild bilateral pediatric edema, what is the significance in this case? So from that point of view, if you are putting any finding, you have to be just be mentally prepared that if they ask why you ask this question, you should be ready to answer that this is the reason I am asking this question, because then the whole viva will go in a different way rather than in the testicular case, which you want your viva should be up to the testicular case, not in the other lateral directions. So I think I will request Dr. Kumar to just highlight how the students should present this finding, which is not very, very relevant, but some examiner don't want to listen these words.
So I think that is a very relevant comment by Dr. Amit. I know sometimes you want that viva should go in the direction which is your strength. So you want to get over with this part of the initial discussion as early as possible. And one of the way is to mention it, but see the mood of the discussion. And if the examiner says, "Acha, iska kya relevance hai?" So you can, someone can immediately say that this is what we routinely say, but it has little relevance here. Then you can move on.
Yes.
Maybe not to emphasize on it for too long.
Yes, I think that's the very correctly way Dr. Kumar has described. Just touch and go. You touch and then go out from that area.
Yes.
So maybe in cases of like abdominal mass or testicular tumor, unless there's some smoking history, better not to mention things like clubbing, pallor icterus, maybe clubbing and other things we can avoid some and
Yes,
not.
Yes. Agree with you.
Okay. So I think Akhil, you can now proceed further to this case.
I think Alok, what is now you have completed the examination.
Yes.
So what's your how will you work up the patient?
So I like to do investigations for one for diagnosis, one for staging, and one for fitness for any treatment. So for diagnosis, I would like to, because I'm suspecting a germ cell tumor, I would like to get done tumor markers, which will be AFP, beta HCG, and LDH. For staging, I would, and to see the disease extent, I would like to do a CCT thorax, abdomen, and pelvis. And based on his tumor markers, may need to consider MRI brain also. And for as part of fitness workup, I would like to do, workup for treatment, I would like to do his hemogram, renal and liver function test, and his um, 2D echo, and if counsel him regarding his plans of his family and consider fertility preservation if needed.
Okay, since here it appears that family is complete, but definitely you will ask about the intent regarding the family, and also if the patient has one child or no child, then what would be the advice and how to do that?
Fertility preservation in the form of semen preservation, which can be done.
Yeah, yeah.
Yes.
What are the instructions for that? How much time is taken, and some more details regarding semen preservation. And first, at the time of counseling, what will explain to the patient? What are the chances of infertility with the treatment?
So semen preservation, I think we'll have to counsel that first they usually examine the semen to check for any baseline infertility and any baseline sperm abnormalities which can be present. And
That is very important. So, what are the chances of baseline abnormality in semen?
with the testicular cancer, I think with
With
10 to 15% maybe infertile.
total semen abnormalities up to 50% patients will have some or the other semen abnormalities. Complete absence of sperm can be seen in up to 10% of the patients. Amit sir, correct me if I am wrong.
Yes, I think your number are so I think what Akhil was, you have to little bit read in between in detail about these issues also. So definitely I think this number is seems to be correct to me too also. So it's around 50% have some or other, either oligo or agiospermia or some functional disorder of the testis, and around 10% may have a agiospermia. It may be 5 to 10%, but definitely it's, so that is important, that why you want to do for a sperm analysis and as well as banking. This is the number. And what is the chance of what Akhil was asking, the with the standard BP regime, the chances of infertility?
70 to 80%.
I think it's around 50 to 60, but I don't exactly remember the number. I think Akhil and then he can, I think it's around 50%, 50 to 60.
50 to 60%. I also
Agree, sir. Say around 50% with cisplatin-based BEP.
So, what is the time taken for semen preservation? And are you aware of roughly the charges? Sometimes when you are sitting in general OPD, the patient will ask, "Sir, ये आपने जो बताया इसमें cost कितना लगेगा?" तो roughly, can you give some idea?
Semen preservation can be done in a day's time, sir, and the cost, I am not very sure.
So I think they usually take, I think, 4 sample or 6 sample, ideally. I don't exactly remember, but it's not one, that is sure. I think it's 4 sample, they preferably 4 or 6, that I have to check. Nandini, how many I've got down?
Yes, sir. Yesterday, when they discussed Vadia, usually ask for 4 samples if the patient has enough time. So they call up to 4 samples. They try to take for better yield.
And in the charges for this,
they had said at Vadia, they said for initial it is some 5 to 7,000, and yearly 2,000 rupees for cryopreserving. Every year they have to pay 2,000 rupees renewal charges to cryopreserve.
This is in Vadia. It may be around 8-10,000 in a just look. So in a private setup, it may be slightly. In Vadia, it's 2,000 rupees per sample for preserving the in nitrogen cylinder. Okay.
Yes.
So in this case, then what you will do in this case? First, suppose the tumor marker comes in the higher side, say AFP is 15,000, beta HCG is, since the pulmonary metastasis is there, it may be say around 2 lakh.
So should I show his investigations? I have.
Then so na.
Yes. Yeah. So this is hemogram where HB is 10.8. Platelets are 4,24,000. Total count was 11,000. And neutrophil was 79.4%. His biochemical parameters, creatinine was 1.24, potassium was 4.9, albumin was 4.09, ALP was 247, and his bilirubin was 0.6, AST was 153 and 155, and his LDH was 2099. His AFP was 1097, and beta HCG was 27,772. And this was his USG scrotum, only USG scrotum which was done here, where they showed a well-defined solid cystic lesion in the right testis, measuring 2.6 into 3.6 into 5.2, and multiple small cystic and hypoechoic areas scattered in the right testis, and multiple foci of microcalcification. The left testis was normal. This is his scan, which was done prior to admission outside, where they found multiple round mass-like lesion diffusely scattered in both lung fields, mainly in both upper lobes, right middle lobe, and both lower lobes, and the larger lesion for cannonball type appearance, and multiple heterogeneously enhancing significantly enlarged mediastinal nodes, largest one being 4.1 to 3.5, and a long segment thrombosis involving the SVC, suprahepatic, hepatic, and intrahepatic IVC, with extension to bilateral common iliac, internal and external iliac veins, and superiorly with a thrombus extending almost to the right atrium. Then there is a lymph nodal mass lesion in the retroperitoneum also, measures 11 centimeter maximum craniocaudal length, mild free fluid in the abdomen and pelvis. So mainly lesions in the lung, mediastinal lymphadenopathy, retroperitoneal lymphadenopathy, massive, and a very long segment thrombosis. These, and as part of this, his echo was also done. Incidentally, this reported as dilated cardiomyopathy with moderate LV function, with the dilation of LA and LV and global hyperkinesia, and no pulmonary hypertension. Yes, these are it.
So what's the stage and the risk group?
Your voice is not clear.
Yeah. So what's the stage and the risk group?
Alok?
Hello? Hello?
Hello, sir is asking the staging and the risk stratification
Am
for
I
this patient.
audible?
Yes,
Yes,
audible.
Sorry, I think I got muted. So I think TX, N3 and M1. And we do not have, orchiectomy is not done, so we do not have an S stage. But in view of, and because, but his beta, but in view of his LDH, you would consider it as S3.
Why one way you are saying that it is not done, and now you're saying, so how
Sorry,
sorry.
sorry.
So I think you can say that pending the orchidectomy, these are the markers which fall, but I will like to exactly assess after. But suppose if these markers are post orchidectomy, then suppose even the orchidectomy has not been done, what is the minimum stage this patient have? Minimum. You have a CT scan finding now. So what is the minimum stage this patient?
Just intermediate at least.
Why? intermediate risk in NSGCT is only by the tumor marker. If you remove the tumor marker, then what is the minimum stage? Even if the tumor marker come down to 0 after orchidectomy, I will say that this will be the minimum stage in this patient because of this finding. CT scan, what is the CT scan finding? CT thorax?
The only pulmonary and mediastinal nodal mets.
So pulmonary metastasis will be, what will be the minimum stage for this patient? Look, you have to, even the tumor markers come down or S0, the lung lesion will not go now. So what is the, in the staging, what is the stage of lung metastasis in testicular cancer?
If there is non-pulmonary visceral mets,
I'm asking for pulmonary.
well, it will be intermediate at least.
Any other third year can want to reply for this question?
Alok sir is asking whether it's going to be 1, 2, or 3. At least the minimum stage on TNM and at least
3. Okay, at least stage 3.
And what is the M?
3B or 3C?
N3.
No, N3, but what is in M?
Sorry, sir.
what is his M staging?
And risk?
M1.
You have to read a little bit. So
What is M1A, M1B?
Yes, so these type of questions you should be.
Okay, M1A. Okay. I mean M1, sorry, M1B because of there is mediastinal nodal mets.
No, look, you have not read it. That means so. So what is the nodal staging in testicular cancer?
N1.
So this is the way usually you get trapped in the exam also. So that means you are saying that if there is a mediastinal involvement, it will be M1B. That's what you meant to say.
Alok, just relax.
Sorry.
Just relax. Tell what is M1A, what is M1B.
Yeah, M1A is non-retroperitoneal nodal or pulmonary metastasis, and M1B will be non-pulmonary visceral metastasis.
Yes.
Now tell what is his stage, M stage.
Yeah, so it will be M1A.
Yes. So it will be minimum M1A, minimum. So that's what I meant to ask, that with the CT scan, at least you can stage the minimum, it is M1A. Whether S, I have to, if the examiners know what is the S, so this is the M, but preferably we need to see the post-op tumor marker, but it is minimum, it is going to be M1A in this case.
So with M1A, what is the stage group minimum? It is 3A, 3B or 3C?
Minimum 3A, sir. And
risk?
One A.
It will be good risk, na?
Okay. Yes.
So good risk will be either S1 or this non-pulmonary, the pulmonary metastasis or non-regional lymph node. Intermediate will be only by S2, and the poor risk will be by either S3 or non-pulmonary visceral metastasis.
Yes.
So how you will proceed in this case? I think we are already running the time 9:15. So in 10:15, I think Dr. Kumar, do you want to add anything in this discussion? Any other relevant question which we have missed?
Alok, can you tell the prognosis of good risk, intermediate, and poor risk in terms of 5-year overall survival?
With the good risk, 5-year OS is around 90 to 92%. With intermediate, overall is around 80% and 75 to 80%. Poor risk is around 50%.
So which classification or from which system you are, or which data you are quoting this?
This IG CCC for.
So is there any other any updated analysis of this data?
Yes.
So this what you are quoting is the IGCC 1, and I think in this year only or last year, I'm not sure. Definitely in 2021 there is updated paper of the same group.
Okay.
So the percentage have increased by at least the major jump is in the in 5-year survival has increased by at least, I think it's around, if I'm not wrong, in the poor risk it is up to 59 or 60%, if I'm not wrong.
Okay.
Nandini or Akhil, you can correct me. So with this IGCC data, they have again looked into all the markers and the survival for these patients with the availability of the better not this is the availability of the better supportive care, more aggressive surgeries, because in the ICGC 1 also the same BP was used, but the poor risk survival was around 48%, the 5-year OS. But with the IGCC 2, with the better cure or better supportive care as a medical oncologist, more aggressive treatment but we have given, and surgeon, they are more aggressive in removing the residual disease, the same survival has improved from 48% to around 60% in the current era. That is the by book. Yeah, and all other the good and intermediate, I think 5% increase, but the jump is in the poor risk.
The 54% are in the update, and originally it was only 41% reported, and now in the new 2020 update in poor risk it is 54%, and in the good and intermediate risk it's almost the similar thing. The PFS improved from 41 to 54 in the poor risk, and OS improved from 48 to 67% in the updated.
67 in the poor risk.
Yes, sir. So, and in the good risk, yes, sir, almost, yes, sir. 48% was the old one, 1997 one, and now the 5-year updated one is 67%.
So I think all our agents, they should read this paper though, because this percentage has drastically improved over time. So we should remember these numbers in the current era. So this is a JCO publication. I think Dr. Nandini or Akhil can circulate to residents. So it's an important
yes, sir.
number.
I'll, sir.
Yes. So how you will proceed in this case, I think we will just have to wind up now. Akhil, you can now take further and just finish in next 10-15 minutes.
Yes, sir. Yes, sir. Now we should go towards management, sir. Yes, sir. Alok, highlight the management for this patient, the treatment plan. Whether you'd like to go ahead with upfront surgery or would you like to start chemotherapy upfront? How will you decide?
Quick. Alok.
Yes, because of the disease burden, I would like to go ahead with the chemotherapy upfront.
I think again I will ask, just a suggestion to all the agents that whenever examiner asks the treatment plan, you have to come with the regime, what regime you are going, and if the examiner is still waiting, tell them the dosage also. So like I repeatedly says in the so like in a breast cancer, if you have decided that I like to go ahead with neoadjuvant, so what is your plan of management? Examiner asks this question, what is your plan of management? So don't say that NACT. So it's better to say that, sir, I will since I planned this patient is planned for a breast conservation surgery, I would like to go ahead with neoadjuvant chemotherapy with the regime of whatever AC, not say AC, with adriamycin and cyclophosphamide with this dosage. Then I will like to go ahead with surgery after four don't say surgery, then say whatever the right modified medical, whatever the plan you have. And then after the surgery, I will like to start the adjuvant chemotherapy with weekly paclitaxel at the dose of 80 mg per meter square for 12 cycles. Since patient is HER2 positive, I will also like to add this. Since the breast conservation surgery is done, I will also like to consider for adjuvant radiation therapy. Since patient is ERPR positive, I will like to, it's a pre-menopause female. So give them the whole schema, don't wait new adjuvant chemotherapy. That so if you tell them the whole plan of a management, whatever the case you have, the examiner know that the student knows how he has to go. You know, we all know that, you know, but in the exam you have to tell preferably in the full chemotherapy name, preferably dosage, if you remember, that would be definitely very great. And all the treatment plan subsequently. So the examiner will know that he knows everything about that. So don't say, I will like to go ahead with chemotherapy. So preferably, I will like to start in this patient with the
Yes, so
Yes.
I'd like to start this patient with chemotherapy. In view of his borderline performance status and his echo findings, I would like to start with the pre-phase chemotherapy, probably with cisplatin and etoposide, with guarded hydration with the monitoring. Depending on his tolerance for pre-phase, I would then consider him for full dose chemotherapy with the VIP, etoposide, ifosfamide, and cisplatin.
Why VIP? Why you are jumping to VIP in this case?
The presence of extensive pulmonary metastasis.
So then this, but
And
say that because standard of treatment is still BP. So you can say that in view of a multiple, I will like to consider VIP over BP. So if you say directly VIP, some may be a little bit. So why is not considering? So tell the standard and why you are not planning to standard treatment. I think Akhil, you can comment on this.
Yes, and also here we know that definitely BP is the standard of care. VIP has more of myelosuppression. So in this patient specifically, there should be some discussion regarding the way we should weigh the balance risk benefit. If there is more myelosuppression, there are more chances of sepsis, and patient is already compromised cardiac function. So here is one of the scenario where though there are pulmonary mets, but still we might choose BP. So or also first before telling VIP, you should tell that BP is the standard of care. But
Yes.
since we want less pulmonary toxicity, so we want to avoid bleomycin, then you can justify using VIP. But you should give the pros and cons and give both the regimens. And first you should tell the BP, and then tell since there are pulmonary mets, we can discuss about VIP.
no,
I think if Dr. Kumar is there, he can also suggest that how these students should take this question of BP versus VIP.
I agree with you, Amit, that by and large, I think so examiner wants to hear BP. That's something which they usually want to hear. But having said that, I think so by and large, now, see, it's acceptable for those specific situations that we do say VIP, and that is also fairly acceptable. BP is something which should by and large remain the first line in this setting, which is what I think most of the examiner wants to hear.
Alok, how will you monitor this patient once you start pre-phase in this particular scenario? What parameters would you look at, and what you mean by guarded hydration? How will you monitor this patient in the ward?
So because of the extensive disease burden, we'll have to monitor for TLS parameters. And with hydration, his monitoring will be with respect to input output and risk for development of decompensation of any heart failure. So we'll look for his respiratory rate, pulse, blood pressure, saturation, and chest findings for any crepitations. And also because his creatinine is borderline, we'll have to monitor his input output and his creatinine every day. So TLS parameters and input output monitoring and monitoring of RFT and monitoring for any decompensation of any heart failure.
Okay. Sir or Akhil, would you like to ask any additional questions?
So I think after completion of 4 cycle of VIP, what you will do and how you will proceed?
We'll repeat his imaging around 6 to 8 weeks after completion of.
First thing, what you will do? Imaging. What is the other thing which we do?
Tumor marker.
Yes. So
Yes.
usually in a NSGCT, we usually take 4 weeks time. 8-10 weeks is the seminoma time. So for NSGCT, it's a more fast growing tumor. You cannot wait for 8 to 10 weeks. So preferably time is 4 weeks after completion of last chemotherapy for NSGCT, and it's around 10 to 12 weeks in semi-node. I think Akhil, you can correct me. I think Akhil is, so it's around, you should not wait for 8 weeks. You should repeat the tumor marker after 4 weeks and repeat imaging after 4 weeks. Suppose the tumor markers is normal and the CT scan shows 3 or 4 lung lesion and around 5 centimeter retroperitoneal lymph node. So what you will do, and what will be your initial imaging in this case, CT or PET CT? For response assessment.
CT scan.
Why not PET?
There is.
So there is no incremental
There's
value
no
of doing
benefit.
PET CT.
Yes.
Yeah,
Yes.
you have to say that, because whatever the why it is, so these are the question examiner asks, why PET CT is not going to help in this case.
There is a teratoma, it won't have any uptake.
Yeah, so whether CT or PET CT, so how we'll approach in this case? So tumor markers normal, 4 lung metastasis, and tumor per abdomen has a 5 centimeter lymph node.
So we'll have to assess for feasibility of the, we'll have to discuss in a multidisciplinary team for feasibility of resection of the pulmonary mets and the lymph node for that.
Yeah, so it's a pulmonary metastectomy with
RPLN.
Say full sentence. Yeah, retroperitoneal lymph node dissection. So suppose the patient has undergone surgery, what you will expect in the histopathology and how you will manage as per the pathology?
We can either expect residual tumor, or if there is any teratoma.
What is the percentage of each component? So out of 100 RPLNDs, what is the percentage of each type of 3 scenario you want to say? So what is these are the questions examiner asks mostly. So you should not fumble in these questions. So what is the percentage?
I'm not sure.
You need to know. So it varies from, but it's around, some says 50, 40, 10, some says 40, 40, 20. So it will be 40 teratoma, 40 fibrosis, and 20 viable. Some literature says 50, 40, and 10. So teratoma, viable disease, and the necrosis. So what you will do in a case of after the histopathology, if it comes out to be necrosis, if it comes out to be teratoma, and if it comes out to be viable disease, what will be your approach?
It's necrosis and teratoma I'll observe and follow with the observation, follow with tumor markers and staging, radiological imaging. If it is
viable disease.
There's viable disease, you'll have to consider for 2 more cycles of adjuvant therapy.
Say which chemotherapy? Again, complete it na 2 cycle of, but you would like to give a FAC in this case. So complete the sentence: 2 more cycle of adjuvant chemotherapy with which chemotherapy you want to add in this case. So what I am requesting that complete whenever you, at least when you are telling any treatment plan, complete the whole treatment plan. I would like to add 2 cycle of BP, or 2 cycle of EP, or 2 cycle of VIP or TIP. So you can say that these are the options. And I would like to add VIP or TIP, that I want to avoid the further exposure of etoposide to prevent. So you have to tell these are the options, and I want to add this because of this reason. So the adjuvant chemotherapy, maybe 2 cycle of BP more, maybe 2 cycle of VIP or 2 cycle of TIP. We generally don't give EP or BP because the patient is already been exposed to the etoposide, and if we give further etoposide, probably the chances of secondary leukemia will increase. But these are the options which are there. So you have to tell the option and why, which one you are choosing in your patient. You have to tell that.
Okay.
Akhil, I think you can ask few questions, then we can finish by a final comment by Dr. Kumar. Akhil, are you there?
Yes, sir. I think, sir, we have discussed most of the important relevant points, sir.
So only one common question which is asked and which everyone should read is bleomycin and mechanism of injury,
Yes,
lung
we don't
injury
have time to
about,
discuss today. So I think,
yes, sir, about,
yeah, so
and the incidence and what are the risk, which patients will be more predisposed. Invariably, everybody gets
invariably,
asked.
yes. So it's not the bleomycin, nothing, it's all toxicities in terms of
Yes,
the
sir.
nephrotoxicity, in
Yes,
terms
sir.
of
And
the
long-term
secondary.
toxicities also are asked. So that also you
Yes,
should.
you have to remember the long-term toxicity, the secondary leukemia, dosage of etoposide, bleomycin toxicity in detail, in detail for bleomycin toxicity, the nephrotoxicity, the and the autotoxicity. So there is a chapter in I think Devita, the long-term toxicity of a testicular survivor. So you have to read in between detail and just note down so that you can answer this question.
Maybe indication for BMT if not discussed, maybe.
Yes, yes, I think we missed the second line in BMT. So I think but Dr. Kumar is suggesting that because if you are doing good, the examiner want to know whether you are. So I think this part, the toxicity and the second line and the further management we have not discussed because of time constraint. So you should read little bit about the bone marrow transplantation also, the auto BMT, the benefit, the second line benefit in this scenario. I think Dr. Kumar, you can say the final comment, then we will close this.
Thank you, Alok. Nice job. I'm sure you will take all those comments and go back, because some of the things we miss in our clinic, which is important, and in the clinic also, but in the run of the getting things done, and it comes from JC, we miss that part. So that is very important, which Dr. Amit initially mentioned was very important, that treatment part, I think so. We have seen our resume, they do a good job here also and in exam also. But the initial part is something which is important, and later part means after treatment. Those two things are all the questions. I hope you have noted it down, because these are questions which is really asked.
Yes.
And that makes learning also nice and answering also easier in the exam.
Yes.
Sir, we had made a list of the questions at the just after our exam.
Correct.
And we had shared.
I think
Sujay had compiled it as well. So
yeah,
we
and
have.
I will suggest the other exam. So those who are going for exam this time, they just update so that the further generation of students will have a easy time. They know what are the questions.
I have noted down the important discussion points, and I'll circulate it amongst all the residents.
What Akhil was suggesting is right. I think so.
We should.
Last year there was a compilation of all the
Yes, sir.
questions. I think
Yes,
Sujay or someone has it. Maybe that can be circulated, and that will make things a bit more predictable.
But don't dishearten, Alok. It's just the rehearsal. So if we are asking today any question, don't be disheartened that I'm not able to reply this question. So this is just the training. So don't. Sometimes the student feel that मेरे को कुछ भी नहीं आता. I have not answered the basic question. So don't be disheartened. It's just the learning, and we want you to be ready for that day. So it's not that we just want to grill you. We just want to prepare you for the final examination, and definitely in your practice also in future. So don't be disheartened that I'm not able to answer the question. That is the way we learn. We go and improve. We will try to improve that. So don't be in a state of shock or depression that I'm not able to answer the question.
Yes, thanks.
So, and one more point to read would be so follow-up after completion of treatment, when, what in based on the stage to which patients will be done, what will be the sequence of investigations during follow-ups. That also they ask, so that is also to be read.
Okay.
So we'll move on to the report discussion. So Deep has to present. I'm not audible.
I think Dr. Pratik has joined.
Yes, sir. Dr. Pratik has joined back, so we can start with the discussion.
I think I will invite Dr.
Can
Pratik.
I share my screen?
Yeah, so just to introduce him, he is one of the very active molecular biologist in our medical oncology lab. So we have invited him for this, so he can just give you the basics and what are the things to be noted whenever we are seeing any report, NGS report. So I think first you present and then he can give you some insight into the report.
Yeah, everybody can see the screen.
Yes, yes.
Okay, so this is a DNA test report of a 70-year-old male, which is being done for the test requested are BRCA1 and BRCA2 germline mutation testing. The sample type here is peripheral blood because we are doing germline mutation testing, and there is a clinical history of the patient that he is having high-grade prostatic intraepithelial neoplasia. With MRI showing Pirate score of 5, and he is being evaluated for BRCA1-2 gene mutations. The test result is patient is found to have a mutation in BRCA2 gene, which is on chromosome 13, exon 4. The variant being leucine to arginine substitution at 117 codon, leading to an autosomal dominant inheritance with variant of uncertain significance as of now. The patient is being tested for BRCA1 and BRCA2 genes. There are no other variants that warrants to be reported were detected in this patient. So,
so when the patient comes with this report, then what you will discuss with the patient and how you will proceed in this case?
Yeah, so our patient is now found to have a variant of uncertain significance. I would just
you have made a PowerPoint. Okay.
Yes, sir.
Good.
So if
before starting this BRCA1 and BRCA2, these are the which panel or what is the panel of gene which are being tested in this, or these are the part of a which gene panel, BRCA1 and BRCA2?
Sorry, sir.
So there are other genes which can be tested in this case or not?
Yeah, so it is HR, homologous recombination gene repair gene
yes,
group.
Yes, it's a part of the. So can you name one or two other?
Yeah,
genes?
so the other mutations will be ATM gene, CHEK2 gene can be tested for.
So that will be, so sometimes the report may contain only BRCA1. When we ask for BRCA1, BRCA2, they will do that only. But
Yes.
If you ask for a HRR gene panel, then they will include all these, whatever you are describing, ATMCC and do these all PLB1, all that.
Right.
Okay. Yes, start. So how many slides do you have in this?
Sir, 5, 6, 7 slides only.
Okay.
So when the report comes as either it can come as likely pathogenic or pathogenic. In that case, when the particular variant which is found is already known to be associated with the condition, the report will be given as pathogenic. But if the variant of the gene has been linked to a disease and clinical features are also matching, but the exact variant which is identified has not been reported previously, then the report will be given as likely pathogenic. In case of our patient, it was reported as a variant of uncertain significance. That means the relationship to the disease is not certain as of now. There are several reasons when they will give a report as a variant of uncertain significance. Like if the patient, the effect of the gene alteration is not known on the disease status, or if there is insufficient genetic data as of now to attribute that mutation to that disease, or if patient is having no symptoms at that point of time or is having other symptoms that is for not expected for this variant that is to be found. So what happens is once there is a VUS, it should not be considered for clinical decision making for that patient. But in future, as more data accumulate over time, a VUS may be reclassified to likely pathogenic or likely benign. That point of time, we can decide what to do next.
So at this, I would like to invite Pratik for the how we classify this likely benign, uncertain, likely. So what is the difference at the molecular level? And then I would like to ask comment from Dr. Kumar that how we in a clinic, how we have to decide VUS and what we should tell to the patient and their family when there is VUS. So how we can counsel the patient regarding the VUS. So Pratik, just
Okay.
tell in brief about this.
Deep, what you said about pathogenic and uncertain significance variants are actually the right statement. But for likely pathogenic variants, what we usually do is that the exact same mutation has been reported in the literature and in the
Pratik, can
databases.
you speak a little louder? Your voice is not very clear.
Acha, is it better?
Yes, better.
Okay, so what Deep explained about uncertain significance, VUS, and pathogenic variants are correct interpretation. But for likely pathogenic variants, what we usually get in the database is that exact same mutation is present, but the clinical association is only loosely reported. And that loose association is usually coming up from reanalysis of the data, and it is not coming from a systematic controlled study. So a likely pathogenic variant will be having, you can say, partial evidence for your actionability. Now, in terms of variants of unknown significance, what you explained is absolutely correct that it cannot be used for clinical decision making. But there is one criteria which one needs to look at. If a VUS is reported in a well-known, well-established gene with clinical significance. So, say for example, in this particular report, BRCA2 VUS has been reported, and this BRCA2 gene has been very well established as a factor which contributes to prostate cancer development. So, if there is a VUS in BRCA2, then one should not ignore it considering that it is a VUS, but rather look at the familial history and talk to the patient in more details to figure out if there is any other evidence indicating that this BRCA might be playing role in the genetic inheritance of the cancer, and if so, if any additional information is found, then it can be actionable.
I will request Dr.
Right.
Kumar that how we discuss with the patient regarding the VUS. So what things we need to tell and how to conceal, because that's a very difficult thing to do in OPD regarding VUS. The family says that there is a mutation. Why you are not starting some therapy based on this VUS?
This is for me, Amit.
Yes. So how clinically we discuss with the patient and their relative, because they say there is a BRCA mutation, report saying in BRCA mutation, and we are not offering any therapy. So I don't even I feel it's very difficult to explain them why we are. They say there is a mutation. Sir, aap dawa kyun nahi chalu? How to tell to the family that and for future also what things we should be take care while discussing this with the patient.
I think so. I agree with you. This is a very relevant question, especially in today's time, because more and more we will be having these reports. Not every lab reports VUS, but looks like more and more labs we are around putting this.
Please mute. Others, please mute. Can we request the other person to mute?
Ashutosh, I think so. You are unmute.
Ashutosh, can you mute yourself?
So, so more and more report people lab they put VUS, so and that discussion goes on. We should put or not at this moment, but looks like more and more is put in the report. Now, second part is that what Pratik said was important, that VUS has got two connotations. One is whatever you are getting genetically, does it have any relevance genetically also in the known database that you do have those genetic changes which has been seen in the past, and that tumor. Second is that if you have those genetic changes, does it have a clinical relevance? So VUS has another connotation, that where it was seen, which tumor it was seen, and that context, it becomes again, useful that we need to remember that VUS is not only for genetic change. Again, the clinical relevance of what is there for the genetic change what we have. Now, how we handle it. One is also Pratik mentioned a bit, and I think so. One case, one of our colleague which we were handling, and Amit is also aware of, that is a good example for it, that we had a VUS that was in BRCA gene, and it was again finally dependent upon what was the family history. And when we had the family history, we didn't look like that it is clearly familial, then we ignored it. So this is for germline, when I said what I said. Second part is VUS in somatic. So if your VUS in somatic, there the significance is far lesser. And as on date, more often than not, when we have seen VUS and try to see that, discuss it and decide a treatment based on that, and some patient I have given it also, doesn't look like it impacts. So VUS should be seen with a lot of suspicion. Somatic, very careful. I don't think so we should veer into starting treatment based on that, unless you have filled everything in whatever you have. Germline also, be very careful, and Pratik mentioned that word important, that if VUS is there, see the family history. And then you can take a call. If the family history is very strong and that VUS is in a gene which is known to have a familial predisposing to familial cancer, then you have some merit to do certain things, because the chain reaction is huge. And this was 2 days back, I think so. Ajay will remember, not in this case, in a different case. This was what a discussion happened in the OPD and went on to whom to test, what will be the sequence, who will be tested further. One, it is test one person, then when the parents will be tested, when the kids will be tested. And then when tested, how it will impact their life. So VUS, we should be very careful about it in today's time.
I think it's a very good suggestion by Kumar, that I think at least particularly I don't usually inquire for a family history in VUS. So that's very important, that if VUS in germline with the genetic history or familial, then we have to take some importance of that. But definitely the view, and as time passes, we are seeing more and more of these reports. The other thing which I can request for resident, that if you see any tumor which is having some familial component, just better to send them to a, fortunately we in Tata have a genetic clinic, because the implication for some, this germline, some may have a very huge, which we may not be able to handle, how to, the psychological, the social, the financial aspect on all that. So it's a good practice if you have any other the genetic counselor in your city or your hospital. We in Tata, we usually send them, and ideally it should be done before doing a germline testing. I think Pratik and Dr. Kumar can rectify me. So it's better that you send them first, let them talk, and then send the sample, because if any germline mutation comes, then it's a very different meaning, and the things may go in a very, very different way from the psychological, social, and financial way. So I think that is one thing which I want to add in that take the help of genetic counselor, genetic clinic, whenever you are planning for this. So go ahead, Deep, with your presentation.
Yeah, so the prevalence of targetable mutations in prostate cancer, up to 20% of metastatic CRPC, castrate-resistant prostate cancer, carry HR repair gene mutations, of which up to 20% are germline and which can be inherited. Another 5% may exhibit MSI high, microsatellite instability high, or mismatch repair deficiency protein. So recommendation for genetic testing in prostate cancer, it can be a germline testing or it can be a somatic tumor testing. Germline testing is recommended for patients with very high risk of prostate cancer, patients with a metastatic prostate cancer, men with intraductal histology, Ashkenazi Jewish ancestry, as well as family history criteria, which includes any positive family member with a BRCA1/2 or Lynch syndrome germline mutation, brother or father or multiple family members diagnosed with prostate cancer at age less than 60 years of age, or more than 3 of any of the following cancers in same side of the family. especially diagnosed less than 50 years of age, which can be bile duct cancer, breast cancer, colorectal, endometrial, stomach cancer, melanoma, ovarian, pancreatic, or small bowel or urothelial cancers. The somatic tumor testing can be considered especially in patients with advanced disease. So biopsy and sequencing is preferred usually from a metastatic site, which will have evaluated and latest mutated genes, which can be missed if we do biopsy from the prostate itself. NCCN guidelines suggest germline and somatic testing panel should include Lynch syndrome associated genes, that is MLH1, MSH2, MSH6 or PMS2, and HR genes like BRCA12, ATM, PALB-B2 and CHEK2. Treatment implications. So this is more important in somatic genetic testing, and in advanced cases, role of immunotherapy is there. Up to 5% of patients with CRPC are found to be MSI high, and pembrolizumab can be used for these patients. Prognostic and treatment implication of HR gene mutations. So germline BRCA mutations are associated with poor prognosis, worse outcome. Germline BRCA1-2 patients on presentations have more T-stage, more Gleason score, nodal involvement, and metastatic disease at the time of diagnosis. Somatic DNA repair gene mutations are present in up to 8 to 10% of localized prostate cancer and 20 to 25% of metastatic CRPC cases. Patients with DNA repair mutations have higher response to PARP inhibitors as well as platinum chemotherapy. So this is some data about PARP inhibitors in patients with HR gene mutation. The first trial was TOPARP-A trial in metastatic prostatic cancer after at least 2 lines of chemotherapy, where olaparib was tested, and it was found to have almost 88% response rate in patients with HR gene mutations. However, if there were no HR gene mutations, the response rate was seen in only 2 out of 33 patients. Similarly, it was tested for rucaparib in Triton-2 trial, and later on TOPAR-B trial was also a phase 2 study where similar results were found, and the latest is a phase 3 trial, PROFOUND, where they have found up to 33% of response rates with olaparib in comparison to abiraterone versus enzalutamide. This was a randomized controlled trial. Thank you. Also, these patients with HR mutations are more responsive to platinum-based chemotherapy, which is not so much tested for prostate cancer, but it is seen in patients with HBOC with ovarian or breast cancers. The response to platinum chemotherapy agents. Thank you.
Thanks, Deep. Only the last 2 question and comments, and then final remark by Dr. Kumar. So, in which patients you are like to do the BRCA testing? Where it is the standard of care in overall, apart from prostate?
For initial treatment of choice is castration, surgical or medical.
No. What are the indication apart from prostate where you will consider BRCA testing?
Yeah, so patients with female with ovarian cancer, young females with breast cancer, or if there is, as seen previously, family history of all these cancers, prostate, kidney, melanoma, all the HBOC, hereditary breast and ovarian cancer syndrome is there. For all those cancers, we can test for breast.
Any other you are missing in the list, if I'm not wrong? So you said prostate, breast.
Yes, sir. Breast, ovarian cancer, prostate cancer, colon cancer, endometrial cancer, kidney cancers, and melanoma.
You will do BRCA testing in kidney cancer?
If there is family history of more than 3, so this is the thing, 3 or more cancers on the same side of family.
That is it's the for the germline testing in this, for the treatment decision making. That why what I meant. For prostate cancer, we take the decision making from the BRCA mutation. Similarly, for this breast cancer, but you have to say when you will do that. So the ovarian cancer, all ovarian cancer will be tested. So if the patient is first time diagnosed with the ovarian cancer, will you like to make your decision based on the BRCA?
No,
Probably
sir.
no. Na? So
No, sir.
I think if I'm not wrong, any other indication is the gallbladder or something. Is there any approval from there for pancreatic? I don't remember. Akhil, is there any other indication for treatment decision making in other malignancy apart from the breast, prostate, and ovary?
Pancreatic you said is important.
Important, yes. So that's what I meant, that you should know that in pancreatic also there is some data which you have to read about, because I'm not aware of that. But as Dr. Kumar rightly put, pancreatic is the cancer where we need to do, because their options are very, in pancreas there are
got
options
approval. I think so. Pancreatic they got approval. Yeah.
Okay, I'm not aware. So I think that's what I meant, that you know where you have to tell which patient at which setting you have to do this testing. So I think just note down the approval, and among all this mutation, what is the best result with this, which mutation in prostate cancer apart from all this list of HRR gene, which is the most responsive gene?
BRCA2 actually, sir.
BRCA2 followed by BRCA1 and then 8.
Yes, sir.
So I think now we will conclude, and we'll just request Dr. Kumar to give the final comment, then we will conclude the class.
Thank you. That was a nice discussion. It was useful, and I think so. A lot of learnings. So thank you everyone, and thank you, Amit.